really appreciate the opportunity to share what we're doing. Well, let me get started because I don't want to run out of time. I am a professor of biomedical engineering and global health, and I direct the Center for Global Women's Health Technologies. And as you can glean from that center name, I'm really interested in women's health. And that essentially means that when you're working on women's health inequities across the globe, our work cuts across different disciplines, different sectors, and different countries. In fact, faculty, students, and staff in my center collectively represent more than 24 countries across the globe. I thought really hard about what story I wanted to share today, and I think that my daughter convinced me that I should share the stories of my students who have really contributed to the impact that we are having on women's health inequities. And if I get my slides, I can show you their pictures. Otherwise, you'll just have to use your imagination. So what we're doing right now is we're working really hard on one of the most pressing women's health inequities of our time, cervical cancer. Why cervical cancer? It's a completely preventable disease, but it disproportionately impacts marginalized populations. And I really believe that if you can solve problems that affect marginalized populations, you can actually create innovative healthcare for all. And I think we're at a time when we really need to be thinking about innovative models that will get healthcare to the masses. Last year was particularly important for cervical cancer because the Director General of the World Health Organization made a bold call to action. He said, we need to end cervical cancer as a public health crisis by 2099. And that elevated cervical cancer to become an international priority, which is fantastic. So I wanted to tell you a little bit about the fact that cervical cancer 100 years ago was considered a deadly disease in places like the United States. But today it's actually a fairly rare disease. So you could argue that we've reached a public health milestone with cervical cancer. And it's largely because of technological innovation, starting with innovations in screening, diagnosis, and treatment. And so what typically happens is cervical cancer is prevented through a 3-step model. The first step is to visit a health facility to get screened through a variety of different screening tests or a combination, and then to come back to a health facility to get diagnosed with a procedure called colposcopy, and then if a lesion is found, to come back yet for a third visit to another health facility to get treated. And this is really effective and has worked in wealthy nations like the United States. So then the question is, why are women dying every 2 minutes of cervical cancer globally? And the reason is logistical as well as cultural. Logistical because many women who are at greatest risk for cervical cancer are far away from centralized health facilities or can't afford to pay, and cultural. If they're not inculcated into the modern world of gynecology, then they might be afraid, they might be ashamed, they might not be aware. So our vision is to think about a model for addressing women's health inequities by putting women at the center of the solution. And we believe that if you can develop innovations that bring hospital quality healthcare to community settings where women can be seen by people they can relate to, they might actually be able to prevent the disease and then be the champions and advocate for other women in their communities to follow suit. And so this is basically trying to upend traditional models of care, which is by no means trivial. So our vision is really entails three distinct steps. One is to essentially bring screening to a woman's home so she has privacy over the first step of this care pathway. And then if she does need to be seen by a provider, she could just walk down the street and get diagnosed and treated by a provider, a midwife, or a nurse in the community setting. And maybe 1 out of 1,000 women who have cancer would ever need to go to the hospital. And so imagine if a woman in a community is screened, for every 100 women that get screened, 98 can complete care at home. So that's what we really want to do, and we think that technology is so important to achieve this goal, but of course, we can't leave out the humanities. We can't leave out the fact that many of these cultures have oral traditions. So we also want to use technology to be able to promote personalized peer-to-peer storytelling so the message gets across within communities and across communities. So when we think about putting women at the center of the solution, we think of disruptive innovation. And we see many examples of disruptive innovation in the consumer industry, but it's really hard to point to disruptive innovations in healthcare. Why don't we see more? It's because we tend to focus more on sustaining innovations that make hospitals better, but that actually makes hospitals inhospitable to many people, because you're not only paying for care, you're paying for overhead. And so one of the things that I really wanted to do is figure out how can we bring hospital quality care to the community setting and maybe health clinic care to a woman's home. What would we need to do to be able to do that? And how can we use that as an exemplar for addressing broader issues in sexual and reproductive health inequities? So let me give you some tangible examples. So remember the clinical colposcope I mentioned? That's a second step of the cervical cancer prevention pathway. Well, that was designed around a centuries-old device called the speculum. And so it works like a telescope. Basically, there's about a foot of distance between the provider and the cervix. And that's what makes this instrument incredibly expensive and hard to maintain and requires an expert to actually operate it. There's no way that a woman who wants to get a colposcopy exam could get that in her community. So how do you reimagine colposcopy? So I had a graduate student that just defended last year, and I asked him how he would think about this problem. And I don't need to trivialize how he thought about the problem, but he imagined the solution first. And he said, what if we could build a spy pen that could essentially be inserted through the speculum so it's proximal to the cervix? And the spy pen has a camera and has a USB charging port, and it's narrow. And so that basically provide the inspiration for a device that we now call the pocket colposcope that is essentially performs equivalently to a state-of-the-art colposcope, the price of a digital camera, fits in a coat pocket, and works in rugged and humid environments like internal body cavities. This product has been FDA cleared and now has been deployed in more than 10 countries, and that happened before Chris actually graduated. And this is an image of a midwife in a mobile clinic in Lima, Peru, using the pocket colposcope on a model of the cervix. And now she's able to use this device in her community setting, something that has been in the past relegated to gynecologists and hospitals. And so all of the women in the community that come to her mobile clinic will have access to a procedure that normally never gets done because most of these women never follow up to that second level of care. I don't know why I'm using cars in my story, maybe sort of contrasting the masculine with the feminine. But, we wanted to push a little bit harder. We have a growth mindset, and we thought, if we can bring hospital-level care to the community, could we bring community-level care to the woman's home? Could we actually introduce the concept of self-driving cars to the landscape of cervical cancer prevention? And one of the barriers to doing that is the metal speculum. I don't know how many of you know about the metal speculum, but it has these blades that are shaped like duckbills. And so the gynecologist essentially inserts the speculum closed into the vaginal canal and then pries the vaginal canal open so that you can get a clear line of sight into the cervix and then a magnified view to look for abnormalities. And so many people have tried to redo the speculum, and it's really hard to do because it's an amazingly effective device, even though many women in the room may not agree. But what we discovered was that the design of the pocket colposcope actually allowed us to imagine a different kind of speculum. Well, actually, no speculum at all. So another student who came after Chris, Mercia Siadu, basically was very interested in women's health, and she actually acknowledged that she didn't know anything about cervical cancer, didn't know about the HPV virus or the vaccine, and she was really intrigued by this idea of democratizing healthcare. And so she spent actually quite a bit of her time at Duke working on machine learning algorithms, but also trying to figure out how to get rid of this speculum. And it was an arduous task, but of course I'd always like to tell you about, when we reach the finish line, because that's fun. She actually imagined no moving parts. And she thought, well, the cervix is actually a very finicky part of the body. It can face up, it can face down, it can face to the side. And she thought, what if I basically designed this asymmetrical tip that looks like a calla lily, where the petals of the calla lily replace the blades of a speculum, the stem or is replaced by the pocket colposcope, and the provider's eyes by a cell phone. Lo and behold, she developed the coloscope. And what's amazing about the coloscope is that a woman can do her own self-exam, and she can actually do this in the comfort of her home, and no matter how badly she does it or how well she does it, she's going to see her cervix. And that's because of this really nifty asymmetrical tip. Now, I don't know if I can actually run this video. I guess I can. And so here's a woman doing her own self-exam, and you can actually get a little bit of a tutorial here on the cervix if you don't know what it looks like. It's the distal portion of the uterus, and you can see at the center there's this beautiful os through which babies come out. And cervical cancer essentially arises around the os, so being able to have clarity around that area is critical. And then you can imagine that with artificial intelligence algorithm, you can either have a hybrid model where a provider and the algorithm serves as readers, or you can do one or the other depending on where you are. So what more? Mercy wasn't satisfied with just developing the coloscope. She actually established clinical collaborations in Ghana. She got approval from the Ghanaian FDA. She trained nurses and midwives, and she actually implemented a study on 50 women, all while she was working on her dissertation. It was very stressful for me. I'm not sure about her. But Mercy's story and Chris's story made me think about how we could bring these skill sets into undergraduate education. So I created a course several years ago, BME 230, called Women's Health and Technologies. And the idea was to use our own technological innovations as well as others to showcase the process of human-centered design, and then also allow students to engage in the hear, create, and deliver phase through projects to sort of internalize these skills. I didn't know what would happen, but it turns out that students became social innovators in the broadest sense. They were interested in innovating for the greater good. And I'd like to just show you some examples of what they did. Okay, well, there is one student missing here, but the first student that I wanted to talk about was Yulia Agudogo, who is from Ghana, and she took the class and was very intrigued by the coloscope, and she actually worked with Mercy on both the design of the coloscope as well as the planning of the clinical studies in Ghana, and now she's at medical school at Duke. Luisa Perez took my course. She's from Brazil, and you can see she's not an engineer, and she decided to apply for a heart fellowship because she wanted to implement the coloscope in Sao Paulo, Brazil, and she's there this year. And then there's Reema Shah from India, who also took my course and decided that she was going to use the insights from the course to create a club at Duke called Duke Flash, so that she could bring STEM education through design thinking to middle school students and students in after-school programs. And then there's Gabriela Asturias, who took my course, and she decided that she was going to start a not-for-profit organization in Guatemala and use design thinking and STEM as a way of creating social activism around clean water, one of the Sustainable Development Goals, because there's this big, beautiful lake in Guatemala, Lake Atitlan, which is contaminated, and students there don't know anything about that. And so she used STEM and design thinking to actually assess water quality, and now they're doing a media campaign with an NGO to demand clean water and really challenge policymakers in doing the right thing. So I couldn't have imagined any of these outcomes. These were student-driven, and you can see many of these students are from many different parts of the world, and I think it points to the fact that when given an opportunity, they can have meaningful impact over the course of their time at Duke and beyond. So I didn't tell you my story because in many ways my story in many ways mirrors their stories, and in fact I found resonance in all of the stories I heard today. I could see myself in that, but I thought I should end, if I have time left, questionable. Should I say something? Okay, you can't tell me not to tell you something about myself. That was a good way to buy borrowed time. Well, actually when I first made my slides and before my daughter told me that I should be talking about my students, I wanted to tell you a little bit about my background. And I had put together some slides about the famous mathematician Ramanujan, because many people ask me if I'm related to him. And, I always sort of hesitate, but then if I want to elevate my status, sometimes I'm tempted to say yes. But the reality is I don't know. But he and I come from the same town in India. We're both Brahmins of Iyengar caste, and our families are very, very religious and very orthodox. And I have to say that, and there was also a lot of marrying within families, so who knows whether we're related. But I think the point I want to make is I was really raised in a very rigid culture where, you just followed very strictly these social norms and cultural and religious norms. And I have to say that being able to come to a place where I could basically sort of engage in inquiry-based education was such a big part of being able to make engineering, for me as a reluctant engineer, really palatable. And I was a professional musician, and I think bringing the arts into engineering is something that I really care about, because I think arts in the broadest sense, culture, humanities, really makes engineering more than just, the sum of technical tools. It allows you to really think about how you can take what you learn to create the greatest good. And I think that, my students really sort of exemplify that. So thanks for listening.